Meaning you there? Okay.
Hi, everybody. Yeah, let's just get set up.
Invite. Yeah, okay.
Just give me 1 second.
Hello, spoiled bread. Hello, Regina. Hello, Rohaida.
Hi, everybody.
Yeah. Hi, guys.
Thank you for all tuning in. We're waiting for the doctors to dial in, and then we will get started right away. And today, the session is with Dr. Tan Heng Hao. We hope you enjoy it, and we want to just start off by reminding you that everybody and all treatments are individual. So, please seek a professional medical opinion before you take any actions. Okay, I think they're just trying to dial in now. This is Dr. Tan Heng Hao from Alpha Singapore, and he will talk a little bit about his experience at Alpha, and he had previously worked with KKH. He's a very popular, runs a very popular practice for, IUIs and IVF and any other kinds of gynecological and obstetric treatment. Good evening, Dr. Tan.
Hey, hi. Thanks for helping to organize this.
No, thank you so much for making the time. We really appreciate it. And we have a lot of ladies and couples dialed in. I think they're very keen to hear about you and your practice. So why don't we start?
Okay.
If I could maybe, just invite you to introduce a little bit about yourself and your clinic.
Okay.
If you could tell a little bit about, your background and how you see public and private clinics in terms of their role and their difference.
Okay, I'm currently the medical director for Alpha IVF Center, Alpha Women's Specialist. This is basically a center that caters to fertility needs, but of course we have the routine care for OBGYN patients, so obstetric patients as well. So this is what I often say, from lab to cradle sort of management. Prior to this, I used to be the IVF director in KK Hospital, so I'm quite familiar with both the practices and the climate in both the private sector and as well as the public sector. So as to your question, what's the fundamental difference? I think both serve their needs. In the public sector, we all know there are government co-funding schemes. In the private sector, we don't have these schemes yet. Hopefully, it will equalize one day. But certainly, there's MediSafe entitlement for the use of IVF. In the public sector, because of the load of the patients, perhaps it's a bit busier, and for some patients, it might be a bit more inconvenient. In the private sector, we have more time with the patients. We can address their needs, perhaps individually, and it might be something that's important for some of our patients out there.
Wonderful. Thank you so much. We will not stand in your way to start. Dr. Tan has a presentation. He has slides. And on IUI and IVF, Dr. Tan, please go ahead.
Okay. Anyway, I'd like to thank the audience for tuning in at this time. I was asked to talk about IUI or IVF, which is better for the patient. And really in this whole few slides that I'll be presenting, the next 20 odd minutes, will be covering the basics of infertility, basics of IUI, revisit some of the fundamentals of IVF, and finally addressing the important question, is IUI or IVF better for the couple?
Thank you so much, Dr. Tan. And if you have any questions, you can always put them on the screen. We will address these later on. Thank you.
So how then do we define infertility? I think most studies or most definitions would put a period of 1 year in those less than 35 years of age, and those who are already trying for 6 months, and those above 35 years of age. And in these couples, we will define that as a failure to achieve a pregnancy. Maybe you can move on to the next slide. There's some basis for this definition. We all know through studies that 85% of normal couples with unprotected sex, regular sex, would conceive within a year of trying, and 95% will conceive within 2 years. In patients with obvious problems like previous infections, irregular periods, or age above 35, then it is better to start the treatment or investigation sooner rather than later. Now, what are the possible reasons for infertility? It's important to note that up to 30% of couples face what we call an unexplained infertility. Frequently, when I meet couples in this category, there's a lot of angst, lots of frustration, because they usually would tell me, I've seen various doctors and everyone say that I don't have a problem, but it's obvious that I have a problem. So the way I position this would be, we wouldn't be able to find any obvious reasons for the problem, okay? And one big category, at least 20%, would be what we call a male infertility, whereby the man has poor semen parameters, namely a low sperm count. Female problems would include things like advanced age more than 40 years, ovulation problems, problems with their fallopian tubes, big fibroids or cysts, and even endometriosis. And it's important to note that lifestyle factors like high BMI, smoking, excessive alcohol intake, and even the abuse of recreational drugs can serve to aggravate the underlying problems of infertility. Now, this is an important slide that I usually use in most of my lectures. It's a simple graph that shows the impact of age on female fertility. As you can see in the green line, as the woman ages, the incidence of infertility goes up, while the incidence of chances of getting pregnant goes down. So if you move across from the left of the screen to the right, as we head towards the 50s, the chances of pregnancy kind of goes down quite dramatically to almost 0%. That's because most women menopause at age 50 or 51. And it's important to note that after 35 years of age, the chances of getting pregnant drops quite steep. And after 40 years, the graph is even steeper than before. Yeah. Now, what then do we investigate when we see a couple? It's really dependent on the time of the menstrual cycle. In the first half of the cycle, various tests will be performed, such as hormonal profile to assess the ovarian response. At this point, we would also use the opportunity to test for the fallopian tubes. It's usually done in the first half so that we are quite certain that the patient won't be pregnant. And in the second half, sometimes patients might be asked to undergo blood tests to assess the chance of an ovulation. For the men, a simple semen analysis will be performed to complete the whole picture. So what are the options to help patients conceive? I think it is important that the couple is mindful of the options. On one end of the spectrum, there are natural means such as trying on your own to get pregnant. We may then couple them with tablets to help ovulation. We may also perform an IUI or an IVF, otherwise known as an intrauterine insemination or in vitro fertilization, that I will elaborate later. It's also important to note that fertility surgeries might be performed to help improve the chances of pregnancy. And of course, at the end of the day, other options like adoption or being accepting of the current condition could be discussed with the physician. So what is an SO or superovulation IUI? Superovulation is a technique or strategy to induce and stimulate 2 or 3 follicles and bring them to maturation before an ovulation. Intrauterine insemination literally means preparing a sperm and inseminating or squirting them directly into the uterus, bypassing the adverse cervical and vagina factors and hoping to improve the odds of a pregnancy. So how is it done? It's mostly done on an outpatient basis. Drugs might be used, fertility drugs such as tablets or injections to stimulate the follicles. It takes over a period of about 10 to 12 days. And scans will be performed by the doctor over 2 or 3 episodes spanning these 2 weeks. And when the eggs are matured, a final injection will be given to trigger the eggs for ovulation before the insemination act itself. So on the day of an insemination, husband usually comes an hour earlier, passes us the semen sample, preferably within the center itself. The semen will then be processed, and we would then inseminate it into the uterus as shown in this diagram through a catheter. And hopefully this would improve the odds of a pregnancy. Medications can be started over the next 17 days before a pregnancy blood test to assess the chance of a pregnancy. So what is the success rates? I think this is something that is on everybody's mind. It's important to note that the fecundity, or what we call the natural conception rate per menstrual month, is about 15%. So in an IUI technique, at best, we're trying to level it up to that percentage of 15. And sometimes, depending on the center, depending on the studies that we quote, it could go up to as high as 20-25%. The overall success rates, of course, varies and depends on the age of the female partner. And a maximum of 3 cycles of SO IUI can be attempted before most of us would recommend an IVF procedure. So I'll go into the stages of IVF. In IVF, it closely mirrors the phases of IUI with quite a stark difference. So in the first half of the cycle, which spans about 2 weeks, similar injections might be given at higher doses and intensities. Same scans will be performed by the doctor. We will assess the follicles, and if the eggs are ready, we will then trigger ovulation. And instead of an IUI, we will perform what we call an egg pickup, where the patient is brought into a procedure room. Then anesthetist will be delivering some sedation, and ultrasound scan will be performed. And as you can see from the diagram, a needle will be inserted carefully through the probe. Eggs are then aspirated into test tubes. That's why it's called test tube babies. The eggs will then be denuded, processed. At this time, the semen or the sperm will be processed, injected, and hopefully it fertilizes into an embryo. So for most intent and purposes, embryos are cultured between day 2 to day 3 or even up to day 5, depending on the clinical scenario, in the hope of getting the best embryo for transfer at the end of the day. So as you can see from the diagram, an embryo transfer is performed similar to an IUI technique, of course with much more finesse, much more precision. And hopefully, again, with medication support, the patient will be diagnosed with a pregnancy in about 2 weeks' time. Yeah. Suffice, and this is an aspect of my practice that I'm quite passionate about. It's about fertility surgery, and surgeries are usually performed through a keyhole whereby little incisions are made, cameras are put into a tummy. Various operations can be performed on the tube, the womb, and the ovaries in the hope of improving the chances of a couple getting pregnant either on their own or augmenting the success of IUI or IVF. So in the workup, in the strategies of IUI or IVF, surgeries might be introduced. Now, we've come to the most important question: is IUI or IVF better for the couple? So a lot of times in my practice, the couple sits before us, we go through the history, and then the couple says, "Doctor, which is better, an IUI or an IVF?" In fact, I would then not think that that's an appropriate question. The proper question to be addressing would be, "Doctor, is IUI or IVF something that I must choose?" There's really no right or wrong answer. It's about making the right choice. And I've always believed in this. Whenever a couple makes a choice, it should not be made out of ignorance. Okay? And some of the factors that we might consider, or the couple should be considering prior to making a choice, would be, what are your underlying problems? Depending on the medical situation, IUI or IVF might be more medically suitable. What are the trade-offs? In other words, what's the complications? What's the side effects? What is the couple prepared to receive in exchange for possible pregnancy. What are the finances involved? In IVF, it can get quite expensive, and this is something that the couple has to be ready for. What are your personal considerations, your timeline, your religion or religious factors or cultural factors? Yeah, in certain religions, IVF is frowned upon, then it might not be something that the couple is comfortable with. And the most important question is, are you guys ready to take the leap? So IVF will be recommended for obvious problems like a low semen parameters. In ladies with blocked tubes, IVF will be the standard of choice or the method of choice. In men where the sperm is surgically retrieved, again, IVF should be recommended over IUI. Now, what are the trade-offs? Certainly, IVF comes at a higher cost. It brings up the pregnancy rates, but the complications could be more serious. Multiple pregnancies, for example, when we put in 1 or 2 embryos, there's always a chance of a twin or triplet, and this brings with it greater risks to the mother and of course to the babies as well. The injections and the treatment is more intense with IVF. Patients might have to go through a bit more side effects. And lastly, in IVF, there's always that risk of ovarian hyperstimulation, a condition whereby numerous eggs are stimulated through the high-dose injections, and patients can fall sick through this stimulation itself, and it can be potentially life-threatening. So those are the trade-offs that one has to be mindful about. Now, this is the most important question. Am I ready to take the leap? IVF, IUIs are never life-threatening. It's always about improving your odds of getting a pregnancy in the way that you want to be treated. So I always tell couples, if they're not ready, we wait. If the time that you're ready is 2 years later, 3 years later, then so be it. So the best time to start is always a time when you both are ready, not so much when you both need them. So what are the prerequisites for IUI? There are usually 3 prerequisites. Firstly, the fallopian tubes must be patent. So in these 2 examples that you see here, in the one on the left, this patient had a previous ligation, probably in a previous marriage. In the one on the right, this is a clear example of a diseased tubes, probably damaged by infections or endometriosis. Therefore, IUI would not be a suitable choice for the couple. The second prerequisite is that there must be a reasonable semen quality. A normal semen count should be above 15 million per mil. And if the sperm count is very low at less than 5 million per mil, then obviously this is a patient who is not suitable for an an IUI procedure. And the last prerequisite would be that the womb has to be normal, as you can see in the picture. The semen is inseminated into the cavity, and therefore a normal cavity and normal tubes would facilitate the odds of a pregnancy in an IUI. So now, the question would be asked most times by the couple, is IUI a waste of my time? Should I go straight to IVF because IVF has higher success rates? I've looked at all my couple friends. They've tried 3 cycles of IUI and they've all failed, and finally IVF got them pregnant. Should we just go straight to IVF? Well, my simple answer would be this. It is only right that IVF has a higher success rates. If I can go to the next slide, please. Yeah. The success rates of IVF is, in fact, more than 2 or 3 times higher than that of an IUI. But rightly so, because A, it is more effortful, it's costlier, there are more drugs involved, and therefore we would naturally expect an IVF to be more successful and to have more success cases. However, IUI is oftentimes a good intermediary step. It is less effortful, and nonetheless, even after going through 3 cycles of SO IUI, most of the times we would have recommended an IVF procedure. So in summary, after this very simple lecture, we would say that IUI and IVF are both acceptable fertility treatment strategies. Discuss them with your doctor, make the most appropriate choice, decide on the option that you are both ready for. We need always to individualize based on a case-to-case basis. And my best advice to all couples is never to give up. I've had couples who have failed IUIs, IVFs, only to get pregnant on their own at the end of the day. And the final note is, if you've decided to take the leap, to move on to the next step, it's always better to start that journey earlier rather than later.
Thank you very much, Dr. Tan.
You're welcome. You're welcome.
That's a wonderful presentation. A reminder that if you have any questions, you can put them in the screen. We do have some questions that come in previously, and these are around also IUI and IVF. One of the questions was, should a patient definitely go for an IUI before an IVF? You explained some situations in which they
Yep.
should go straight to an IVF. But are there situations, and is it common that they should definitely, in your opinion, go for the IUI first?
Well, as I mentioned, it really depends on the clinical situation. Age, to me, is the most important factor. I think generally, the older the couple is, or the female patient, the more likely are we to explore IVF rather than IUI. We have had, we have looked at studies across the world, and most studies point to a simple fact. IUI is perhaps a reasonable option in those less than 40 years of age, where the success rates is a bit more acceptable, and it's quite dismal in couples above 40 years of age. So in couples above 40, probably, if they're willing, IVF might be a more suitable option from a medical perspective.
One of the other questions is, what is the success rate for IUI on the first try? And does the success rate of IUIs increase after a number of tries?
So there's this concept in fertility treatments, what we call cumulative success rates, means the success rates of individual cycles add up. So for example, in a single IUI patient, the success, hypothetically, we're talking 20%. So in let's say if I have a population of 100 couples, 20 would be pregnant, and that leaves 80. If I were then to perform a second round of IUI, another 20% might get pregnant. So let's say another 15 get pregnant. And at this point in time, 35 get pregnant out of the original 100. And if I perform a third IUI, in the remaining patients, another 10 get pregnant. So at the end of the day, the cumulative success rates has been quoted to be as high as 50, 60%, depending on which study you look at. But certainly after the third IUI, the success rates kind of stagnate. And that's when most of us would recommend an IVF cycle. However, this is just on paper. In a practical scenario, most of our couples, after 1 or 2 cycles of IUI, may then elect to go for an IVF procedure.
If you look at all your couples, is there a percentage of the couples that you would say move on to an IVF after an IUI?
Yeah, I think I would say majority would entertain the thought of an IVF. However, for varying reasons, they might differ. So as I explained in my slides earlier, there are multi-factors why some may differ in IVF, personal factors, timeline, not being ready, but I think it enters their mind. The other problem that I see is sometimes there's a discordance of opinion between the husband and the wife. The wife might be ready for an IVF, the husband is not so ready because he thinks it's not so natural, and vice versa. So these are factors, but I think underlying, they're all entertaining the thoughts of an IVF, but there may be certain other factors holding them back.
That makes a lot of sense. One of the other questions that we had from one of the ladies, I just want to pick it up. She had asked if you have one tube, one patent tube, can you do an IVF? An IUI.
IUI, yeah.
One blocked. Yeah, one blocked and one patent.
I would have numerous stories on that. Yeah. I think most of us would understand or try to understand that the way we diagnose a blocked tube is important. I think most of the viewers out there would know that the HSG, which is the test, an X-ray test to diagnose the patency of the tube, is one of the commonly used investigation to diagnose a blocked tube. I think unknown to many couples, the incidence of false reporting is quite high. So the incidence of falsely reported as blocked tubes can be as high as 20 to 30% in some studies. This is because of the way that the test is done. You ask any patient who has had the test, it's quite uncomfortable. Sometimes they will be squirming and moving around in pain and the spasm. And therefore, tubes might be falsely diagnosed as blocked. So in response to that, yes, I've had couples with seemingly blocked tubes. For whatever reasons, they are not keen for an IVF, they perform an IUI, and they have gotten pregnant at the end of the day. So I think it's very situational. Again, age is important, and it's important for the physician to look at all factors before recommending the next step.
Understand. One of the other questions we had was, what is the required sperm motility and morphology for IUI to be successful? Other than the sperm count, what about the other factors?
Okay, when we analyze the semen quality, there are a few parameters we look at. The most important, and I say it again, the most important would be the sperm count. The motility, the morphology is expressed as a percentage of the sperm count. So if you have a very high sperm count, say in some instances 50 million per mil, whatever the percentages are, it's just a fraction of that 50 million. So I think there's no hard and fast rule. If we have a sperm count above 10 million, motility of a reasonable percentage, we could attempt an IUI. And after processing, the percentage of motile sperms ideally should be more than 1 to 2 million. So these are all indications that an IUI would be a suitable option for these couples. Yeah.
There are two ladies who would like to know about whether an IUI can be done under anesthesia, whether that will impact the sperm, and is it possible to undergo IUI when you have vaginismus?
The simple answer is yes. However, there will be certain challenges. So as I explained earlier, a hallmark of an IUI is a coordination of the ovulation with the insemination. And in a routine practice, we usually perform vaginal scans because this gives us perhaps a closer or greater accuracy in assessing the follicle. So in patients with vaginismus, we would then have to depend on an abdominal scan. Rarely do I perform a rectal scan, means we put in a probe through the rectum, but usually through the vagina, through the abdomen. So the coordination or the assessment might not be as accurate. Certainly at the time of an IUI, the anesthetist would have to be present to give sedation so that the patient is relaxed for an IUI procedure. It will not affect the quality of a sperm insemination.
Understand. There are a few questions about the difference between a normal IUI, unmedicated, and a superovulation IUI, and then also in terms of the amount of the medication given for the superovulation. How would women know when is it more optimal to do a full IVF versus a medicated IUI?
I think the comparisons between IUI and IVF is really, we're talking about apple and oranges here. They're totally different in concept. So we will never pitch the success or the strengths of a superovulation IUI with an IVF. So these two are separate. However, it would be reasonable to compare SO or superovulation IUI with just a normal IUI itself. So as I alluded to earlier, IUI is an act of inseminating the semen into the womb when ovulation happens. We must understand, how do we increase the success of IUI? This has oftentimes been analyzed, debated by scholars over the years. And the consensus has been, to improve the success of an IUI, you must coordinate the timing between an insemination and ovulation. That's point number one. Point number two, increase the number of follicles so that when you increase the number of follicles, you increase the odds of a pregnancy at an IUI. However, this comes at an expense or risk of multiple pregnancies. So there's a fine balance. So for reasonable practice within safety limits, we are aiming for at best 2 or 3 follicles, right? So we're balancing the chances of a pregnancy with the odds of a multiple pregnancy. So certainly if you do a SO IUI, in summary, the success rates goes up. However, the risk of multiple pregnancy, i.e. twins or triplets, would also go up.
Understand. With regard to I think the question one of the women had was really more around medication that you would have to take to do the superovulation IUI, and whether that has got any comparison at all to the amount that you would have to do for an IVF. So I think they're trying to compare, how much medication, how many injectables do I have to take over how many days? Yeah.
Okay.
Is it very different?
Yeah, the answer is, in a simple nutshell, the doses, the intensity, the number of injections that we use in the IVF is much more than the IUI procedures. I've always been a believer that if we are performing an IUI procedure, keep it very simple. If we are going to increase the injections, increase the doses, we might as well perform an IVF. So for me personally, in an SO IUI procedure, I usually combine tablets with injections. The use of tablets aids in the stimulation of the follicles so that we don't have to depend so much on the injectables. And when I employ injectables or injections for an IUI procedure, I usually space them out. So maybe 2 or 3 days an injection. This minimizes the amount of the number of times that the couple has to jet themselves. Yeah. In IUI, in IVF, it has to be daily injections usually. Of course, there's some preparations where it's one-off injections, but most of us engage in daily injections from day 2 menses, day 1 menses, all the way to day 10, day 12, depending. And most times it could be 1 injection a day for the first 5 to 6 days before moving on to 2 injections a day.
Understand. And for a super ovulation IUI, how many days would they be expected to take injectables for?
The duration of stimulation is between 10 to 12 days. As I said, many physicians have their own way of stimulating. Some physicians would employ daily injections at low doses, but I would usually space them out and alternate the injections. So for me, typically in a whole SO IUI cycle, I would just deliver or administer 3 or 4 injections maximum.
Understand. Thank you. I think if we could move on a little bit to the IVF questions, there are still quite a few of these. One of the questions is IVF the only way out for blocked fallopian tubes?
No. When we talk about blocked fallopian tubes, it's always a discussion between surgical clearance and IVF. So in certain instances, surgeries, which I brought up in the slides earlier, that's why I introduced that 1 or 2 slides on surgery could be employed. There are many surgical techniques to unblock tubes, to clear the tubes, to even re-anastomose the tubes in previous ligations. And the chances of success is quite, I would say, encouraging. But in certain instances, IVF is preferred. For example, age again. In a couple who is above 40, we would rather move straight to an IVF. In couples with concomitant problems like low sperm count, low ovarian reserves, IVF would be a preferred recommendation.
There are 2 questions that seem to come up very often. The first is, would you recommend Clomid or Letrozole to a lady who ovulates regularly before recommending an IUI or IVF?
Okay. It depends on which perspective you're coming from. If you are a purist, then you look purely at evidence, and evidence comes from research studies all over the world. The stand is that these tablets are of no use. But I believe that most of us, if the couple would be, after a thorough discussion, would be willing to try naturally for a few months, most of us would just prescribe a few cycles of tablets. How I believe these tablets work would be it gives the couple impetus in the next few months to try. If you want to call it, it's a placebo effect, but it gives them an impetus. And certainly there's no harm in giving them the tablets. But if you're purist, the evidence says there's no real benefit.
Understand. The other question that we seem to be sort of continually getting is, are supplements important, and do you recommend them in your process of IUI and IVF?
Yeah. Now, there are many supplements in the market: vitamin E, vitamin D, DHEA, coenzyme Q, etc., etc. Even TCMs, Chinese herbs, etc. I mean, most of these supplements are still subjected to scrutiny. Research is still ongoing. I think 2 of the most, I would say 2 supplements out there that has the best evidence would be simple vitamin D and vitamin E. I think there has been a wealth of evidence that vitamin D deficiency in ladies is associated with infertility, and vitamin E supplementation in men helps improve semen parameters, DNA fragmentation, etc. So these are the 2 supplements that I usually recommend. Anything else, I think the evidence is still 50-50. There's no robust evidence, but certainly there's no harm. I think it's important to emphasize at this point, it's important to have a good diet, and supplements are never replacements, right? So good diet and good healthy lifestyle.
Understand. There are two questions very specific to IUI, so I just want to address them. One question is, what is the purpose of the gonadotropin alpha injection in IUI? I think this is for the release of a mature egg. And if she has already ovulated, does she need to take the injection? The second question is really quite similar. For the superovulation IUI, must you have a positive OPK before proceeding with the IUI insemination?
So the whole idea of IUI, at least from my perspective, is a few things. Nurture the follicle, mature it, grow it, and when it's ready, control the ovulation. It's important to have control here, and control comes in many ways. The timing of the insemination, because if we can coordinate the ovulation with the insemination, it certainly improves the odds of a pregnancy. If ovulation happens over a long weekend, then certainly IUI is not going to work. So a trigger jab, what we call a Ovidrel, a trigger injection that stimulates the ovulation, would be given, ideally in a patient where the eggs are already of an ideal size, but ovulation has not happened. Then we can time the IUI better. However, in some of our patients, ovulation would have taken place already on the morning of a scan. How do we know? When we scan, the egg is of a very mature size. We would then proceed on to check the urinary LH. It would show a positive test. It means that the IUI then has to be done as soon as possible within 24 hours. Now, as to the question whether we would still go ahead and give a trigger jab, I think it depends on clinicians. My personal preference is yes, I will still give a trigger jab to ensure that ovulation happens, because ovulation is an important prerequisite for pregnancy.
Understand. If we can move on to some of the questions on IVF. There are many questions about how is the IVF performed differently in a private clinic as versus government hospitals.
Yeah.
And maybe if you could speak a little bit about how Alpha is different to other private clinics, the kind of success rates you might have for maybe slightly older patients. I think many women are interested to make that decision.
Let me talk about, say, between public hospitals and private hospitals. I've been on both sides of the fence, and therefore I hope to be able to give a balanced perspective. I think private and public centers both have their importance in meeting the needs of the people. One major difference certainly would be the funding schemes which are available in the public system. However, the individualized care that we deliver to patients in the private sector, I think you can't compare that with a public sector, and rightly so, and because of the load that we face or I faced a few years ago. But however, an important component of an IVF is not just in objective success rate. So a lot of couples would always ask, what's your success rates? Tell me the success rates. Now, I have this philosophy. When I see an IVF couple, they will invariably have only two outcomes. Either they walk out pregnant or they walk out not pregnant. It's a given. For the pregnancy, well, it's something that we hope for. For those who are not pregnant, that's when the support, the care, the individualization that we give to them is important. So I think that is something that the private sector can meet because of the time spent with them. In Alpha, I think we have across the groups, we have branches in Penang, in KL. We have shared experiences. I think the technology that we use might be slightly different. Every center has their own unique technology processes, and I would like to believe that our processes that we have are quite robust. I've been able to integrate the techniques of our sister centers in overseas and with whatever that I knew from the public sector, and perhaps come up with something better for our patients here.
Understand. Do you think that the use of AI technology at private clinics is very useful?
Again, a balanced perspective. AI has its role. Certainly, it's not for everyone. As an example, what AI does is that it uses artificial intelligence and capture from its information from big data and assesses the embryos. What we are doing now is looking at the embryos through embryoscope scoring, through observation from the embryologist. AI gives a different dimension, a different perspective. So in a patient where they have had multiple failures, they have had multiple miscarriages, and they have had many embryos before them, I think AI gives another dimension in allowing us to choose the best embryo. So again, I think it's important for the clinician to be able to weave AI into their practice, ultimately for the patient's greater benefit.
Understand. Have you seen improved success rates from this embryo grading process?
The answer is yes. It's about reducing the interval to pregnancy. So if you think about it, in IVF, if I had harvested, say for example, 10 embryos, and in these 10 embryos, 2 embryos or 1 embryo out of the 10 is destined to succeed. Certainly, if I transferred all 10 over, say, half a year, 8 months, you will get the pregnancy at the end of the day. So what AI, in the spirit of embryo selection, so I say again, in the spirit of embryo selection, we're able to shortlist the better embryos and hopefully get the patients to their destination earlier rather than later. So that's how AI works. And hopefully we avoid failures and miscarriages along the way. Yeah.
Understand. There are a few questions on some of the things that you mentioned just now. One of the ladies is very keen to hear more about the fertility surgery that you mentioned, and how does that relate to people who may have low AMH and possible endometriosis?
Yeah. So as I alluded to earlier, fertility surgery is actually something I'm very passionate about. I started out in my career, in fact, being more passionate about fertility surgery than other aspects of treatment. So I think it's not for everyone. We have to move away from that mindset. All cysts equals surgery and all fibroids equals a surgery. It's important to understand that surgery is a double-edged sword. It can help you, and also it can cause collateral damages, reduce ovarian reserves, cause more scarring, etc. It has to be properly applied. Now, when it comes to endometriosis, the clinical dilemma is always, do I remove a cyst at the expense of a potential drop in ovarian reserves, or versus a benefit of potentially improving the success of a pregnancy? So these are things that we have to consider, we have to discuss. And I think it's on case-to-case basis.
Understand. One of the other questions that we have is with regard to, you mentioned that there's a recommended BMI, and they wanted to know what is that recommended BMI for women who are approaching IVF, and if you are a diabetic, what is a good sugar level before you would encourage them to proceed with the IVF?
I think certainly for IVFs, or even for that matter, any other procedures or risk mitigation for health reasons, we are always better to deal with a patient with normal BMI. If someone has a high BMI of above 35, or there's morbid obesity, I think there are risks, material risks to the patient during an IVF procedure. The efficacy of the drugs will be lessened considerably. The risk of anesthesia will be increased at the time of a pickup, and even after pregnancy, I think the material risk to the pregnancy is real. Higher risk of miscarriages, preterm delivery, etc. I understand and I appreciate the difficulty in some couples trying to achieve a normal BMI. I think it's important to try to reduce the weight. Even a 5 to 10% reduction in weight brings numerous benefits to the overall outcomes. So if you ask me for an ideal BMI, preferably less than 30, preferably, but this is a real world and we deal with many patients in higher BMIs, and such is life.
Understand. One of the questions that we have is around types of protocol. How are the types of protocol different in your clinic? And there are some questions from women, I think, who have had some frustrations. There are questions, the two questions are, what if there's a recurring failure to extract eggs? And the other question, the other point of frustration, around recurrent implantation failure. So maybe if you could speak a little bit about protocols and your response.
I think the confusion is out there. I think even the clinicians themselves cannot agree on what's the best protocol. There will be concepts like the long protocol, the short protocol. Do I perform a fresh embryo transfer? Do I go ahead with a frozen embryo transfer? Do I transfer a day 3 embryo because my doctor tells me the embryo survives better in the womb? Do I go for a day 5 embryo because the other doctor says that if they don't make it to day 5, they're not going to get you pregnant anyway? My simple answer is there is no one size fits all. I've had numerous examples where a patient comes in filling numerous fresh transfers. We schedule an elective frozen transfer, she's pregnant. I have patients that come in, just recently, I share with you a story. I had a patient who had recurrent failures from blastocyst transfers. She has had, I think, 3 or 4 fresh IVF done prior to seeing me. She went for blastocyst culture. Blastocyst means letting the embryos grow to day 5, and she's been failing them. I tried again the blastocyst culture. I failed. She went back. She lost some weight. She came back 3 months later, healthier, and she was 40 years of age. We discussed. We decided this time to go for fresh transfer because it was never on the cards in the previous cycles. We've decided this time to go for fresh day 3 transfer. We put in 2 solitary, we had only 2 day 3, and she's now pregnant with twins in the 2nd trimester. So the difficulty I face, or we clinicians face, is that what is the optimal regime for patient? And I strongly believe that different patients react and respond differently. We really have to individualize. I hate to say it, but I hope the patients don't see this as a trial and error. Some patients have owned up to me and say, "Doctor, I feel like a guinea pig. It's purely trial and error. This doctor tells me, let's go for fresh for what it is worth. The second doctor says, since you've tried fresh, let's try frozen." It's not exactly trial and error. These are all proven techniques. The difficulty we have is knowing which patient would respond to which technique. Trial and error means we don't know the outcomes. We know the outcomes. We just don't know who are the candidates for these outcomes. So I think it's important to have a discussion. Find someone that you trust, that you can have a rapport with. I think that's the most important. A lot of patients are asking on Instagram, which is the best center, public, private, is it center A, center B? I think it is most important to have trust and rapport in the doctor-patient relationship. It's absolutely important, right? Yeah. I think that would be it. And I think one of your other question is recurrent implantation failure. It is a real problem. Yeah, recurrent implantation is a real problem. What's the definition of implantation failure? We have to be very prescriptive on this definition. It means that the patient has had numerous transfers with good quality embryos and yet fail in the absence of known uterine problems. So these prerequisites have to be met. If the patient had numerous transfers, but they were poorly graded, low quality embryos, might not be strictly implantation failure, right? Textbooks have been written on this. And in a true implantation failure case, it is very frustrating. Empirical treatments have been proposed and written up. For example, doing an empirical surgery, looking at the womb lining, looking at empirical treatments with intralipid, with steroids, etc. But I think none have been proven absolutely to work.
Understand. That was one of the questions as well. People talking about aspirin, Clexane, intralipid. What does the endo scratch accomplish or do? That was one of the very common questions.
Yeah. So what is endo scratching? I think maybe for the viewers, endo scratch, very simply put, is a mere technique whereby we insert a device into the womb. It could be as simple as a little straw-like catheter. I don't know if I have it here, but it's a simple straw-like catheter that we put into the womb. And in the act of doing that, we traumatize the womb lining. And when the womb lining regenerates and heals, it purportedly secretes certain chemicals that improves the implantation of the embryo. Now, when this idea was mooted many years ago. It took the world, IVF world by storm. Every doctor who faced an implantation failure would do an endo scratch. I think in recent years, there have been emerging studies, properly conducted trials, randomized controlled trials. These are the highest levels of trials that kind of put a dampener on this endo scratching. That means if you did it on the empirical, the evidence might not be so clear. So again, we are back to square one. Is it useful? Is it not useful? Again, in the clinical practice, what I do is that if it's something not harmful, it's not expensive, it's not invasive, it's not going to cause discomfort, why not? Why not? So most of us would still include this endo scratching in our strategies in implantation failures.
What about a hysteroscopy?
Hysteroscopy means putting in a camera into the womb cavity when the patient is under sedation in a day surgical setting, having a look and removing any lesions like polyps or fibroids that we may find along the way. I think hysteroscopies should be performed under a few circumstances. So a typical scenario would be when we did a scan, we suspect a polyp, a fibroid, we might offer a hysteroscopy before an embryo implantation, or in a couple where there is documented recurrent implantation failure. I think most of us would still offer a hysteroscopy, and studies have shown that there's a high incidence of pickup of incidental problems that were not diagnosed prior to the hysteroscopy, and it helps the patients.
Are there any other tests that you would recommend for recurrent implantation failure?
I think, well, we can compartmentalize them. If we have recurrent implantation failure, blood tests could be performed to look at autoimmune antibodies. But to be very fair, this category of patients are quite rare to be picking up autoimmune antibodies. They are a rare entity, and I don't see many of these patients over the years. Vitamin D deficiency can be screened for. If there's vitamin D deficiency, as I mentioned earlier, please go ahead and take vitamin D replacements. There have been patients or doctors who have offered intranlipid, Clexane, aspirin, again to varying evidence out there. I think what is quite interesting in the last few years would be the use of ERA or endometrial receptivity analysis. What it does is that we put a patient through a mock cycle, and on the day of the supposed transfer, biopsy the lining and send it for an analysis. And then the lab would be able to tell us, is that the correct day of transfer or not? Most times it is, sometimes it's not. And if it's not, then we then alter or vary the timing of transfer itself to help improve the chances of our pregnancy.
Understood. One of the questions we had is natural or medicated FET and what you would recommend.
Okay, I've done both. I've done natural FETs and medicated. So again, for the viewer, what natural FET does is that you monitor for an ovulation. Once ovulation happens, you transfer the embryo in at the designated time, just like your body's natural response in a pregnancy. A medicated FET means we prescribe tablets to build the lining, and when the lining is of a suitable thickness, we transfer the embryo. Now, on paper, again, success rates are similar. If you look at most studies, success rates are similar for natural FETs and medicated FETs. However, certain differences exist. I think natural FETs, what's the benefit? The ingestion of medications are very much decreased. Sometimes it's just some ovulation tablets. So the side effects that the patients experience will be very much less. Everything is a bit more natural. Medicated FETs, however, includes taking daily hormones, hormonal inserts, and this causes a lot of side effects. However, the trade-off of a natural cycle is that the monitoring is more onerous. Sometimes we may miss the ovulation, or we're not quite sure when the ovulation happened, and that would screw up the transfer timing. Medicated FET is more regimented. It's more scheduled. It's more fixed. You can vary. If you're not free on a Tuesday, I could then extend the medications and do the transfer on a Wednesday instead. In natural FETs, it's very unforgiving, unaccommodating. right?
Yes.
So those are the differences.
Understand. We have some women for whom they had no response to stimulation, so they wanted to understand what can be done with regard to changing protocol, and also what tests you would recommend to detect possible poor responders to IVF stimulation.
Well, if you talk about poor responders, I think we can, at least in my mind, categorize them into a few groups. Were they underdosed to begin with? Some poor responders might not be really poor responders. It's just that they were not given enough doses. So for example, if someone needed a dose of 450 IU, but was given 200, of course, they will not be responding. That's poor response, but it's a pseudo poor response. The true poor responders are those that don't respond despite maximum doses of injections. Those are the true poor responders. In this group, sometimes they could belong to, and most times, in fact, they belong to the group of diminished ovarian reserves. That's a difficult group to deal with. There's no silver bullet. It might mandate minimal stimulation, natural IVF, which means we tap on the body's response to stimulate just 1 or 2 or maybe 3 follicles at max. There's a very rare group of poor responders where the problem probably exists at the receptor level. We have no test at this moment. It's all done in a research setting. In other words, the reserves of the patients are good, but at the receptor level, they're unable to bind to the drug to stimulate the eggs. Those patients have been documented in literature before, but again, these are very rare entities.
Understand. If you fail a IUI or an IVF, what is the duration that you would recommend they wait to embark on another round of IUI or IVF?
So I've had this question asked. It depends on which perspective you're looking at. If you're looking purely as a medical perspective, a physiologic perspective, and I view the patient as someone no different from a robot or car, then of course you can begin the next cycle almost immediately. The biggest obstacle, however, is themselves, the emotional readiness. Are they ready again to pick themselves up? So if you ask me, because of these factors, most times there's a delay of perhaps 2 or 3 menstrual months, not calendar months, menstrual months. 1 menses, 2 menses, and then they're ready to go.
Understand. And for those who have already failed both IUIs and IVFs, there's a question of what can they do next?
So it depends on the underlying cause. I mean, this question is quite open-ended. Really depends on the underlying situations. But let me give the answer, or I try to answer them in broad-based perspective. Remember my last, in the summary slide, my last sentence, never give up. I have had patients got pregnant on their own. So this is something that I always emphasize. I've had many patients come back to me pregnant on their own despite having failed IUI and IVF. Just recently or currently or this morning, I saw a patient who is now pregnant in her 40s on her own. She failed a cycle of IUI, failed a cycle of IVF, has very poor ovarian reserves. And before she was about to embark on another round of IVF, she's now pregnant on her own, right? So don't give up. Certainly, depending on the scenario, you could attempt another IUI or IVFs. I've always stated this, IUI and IVFs, if you view it, it's like a game of probabilities within the confines of science itself. So the more cycles you have, certainly the cumulative success rates goes up.
Thank you so much, Dr. Tan. There are some very big fan questions. I just want to make sure that you answer them. For those who ask, do you see normal gynae cases if the patient does not require fertility treatment? And do you deliver the babies, the IVF babies from your clinic?
Yeah, the answer is yes. My philosophy of I don't call myself an IVF doctor. I call myself a fertility doctor. An IVF doctor means you come in, you walk away with an IVF. No. For me, when you come in, let's review your case holistically and decide on the best way to get you pregnant. And my philosophy is I will only consider a success if I deliver the baby to them, not just an embryo. So that the simple answer is yes. I was trained as a obstetric and gynecologist, so I do both general gynae and general obstetric cases as well.
And one more question that's, I think, specific to your clinic and practice. Must I go to a hospital to do IVF or IUI?
No. Everything is done in-house. The good thing is that my clinic, where I see all my patients, is just beside the IVF center. So it's all done in-house. However, for deliveries and major surgeries, then of course we will have to then go on to a hospital to perform those procedures.
Thank you very much, Dr. Tan.
You're welcome.
There are still other questions, but we will, note those down and send them through to you. Thank you so much for your time today. Thank you for all the listeners and readers who have dialed in. You clearly, Dr. Tan, have so many fans and so many new patients coming.
I apologize if I'm not able to answer some specific concerns of the audience, but it's sometimes just impossible to answer everything in detail.
Absolutely. You've been so generous with your time and your knowledge. Thank you so much
You're
for
welcome.
today. Thank you, Dr. Tan.
Bye-bye.
Bye-bye.